think that's an important question that, to be honest, I don't feel that we know the answer to, and I think that's something as a community we really need to work to figure out. When we look at the data for nivolumab and ipilimumab, as compared versus sunitinib in the frontline setting, it showed this improvement overall survival. A couple of caveats from that study is, first, if you look at those patients with good risk disease, the response rate, progression-free survival, are actually higher with sunitinib than with a combination. And that actually led to the FDA approval for the first time in renal cell that nivolumab ipilimumab is only approved for those with poor intermediate risk. So I think right now, while there's still some activity of sunitinib in those with good risk disease, a TKI therapy is very appropriate for those with good risk disease. I think the second caveat is that in the study, Checkmate 214 was really accrued prior to the approval of immunotherapy in the United States. And so less than 30% of patients who got sunitinib actually crossed over to receive immunotherapy because they didn't allow crossover until the data was reported just 2 years ago. And so one of the questions would be, had everyone who received sunitinib been able to receive immunotherapy in the second line, will we still see that same magnitude of benefit? And we don't know that answer, but it's something that as I look at the current trials, which have a comparator arm of sunitinib, I feel that those trials still have equipoise, and that with these patients who do get randomized to receive sunitinib, provided if they progress, we randomize them quickly or progress quickly to a immunotherapy-based second line, that we may be getting the same degree of benefit.